Yeah. So welcome back. Today's my first lecture is on factor deficiencies. Normally the blood is maintained in a liquid state, but what happens when there is any trauma? What will happen? There is a blood will clot. So what happens in the blood clotting? Three important things play a role. First of all, the blood vessel. Second, the platelets. And third are the clotting factors. So when any of these have a problem, what will happen when there is a trauma? There would be a prolonged bleeding. So today's lecture is concerned about what will happen when there is a defect of any of the clotting factors. Now, the various these things which I said, platelets, blood vessels, and clotting factors, they present differently clinically. What is the difference? Can you tell me? Yes? What is this thing? These are purpura, petechiae, and large ones, this is known as ecchymosis. This takes place when there is a defect in the platelets or in the vessels. Whereas what you see over here, is there a bleeding? But can you make out that there is a deformity in the knee? That is known as there is a bleeding inside the joints, which is known as hemarthrosis. Okay? And this deep bleeding takes place when there is a defect in the clotting factors. Remember, the clotting factor deficiency, they present later, on a later stage, because primary hemostasis is obtained by the platelets. The later, the clotting factors play a role. So the clotting factor deficiency manifests later, and they present in the form of deep bleeding, whether it's there in the joints or it can be in the form of hematomas. Okay? So this is how the difference in the bleeding is there between the both of the entities. Now what happens? You must be familiar that the clotting factors, they are labeled 1 to 13, and they act in a sequential manner. That is, there is an intrinsic pathway, there is an extrinsic pathway, and they converge to the common pathway. The common pathway eventually leads to the formation of the fibrin strands, which stops the bleeding. Now this assessment of clotting factors pathway, we do by different tests. What are those tests? Yes? We use the prothrombin time, the partial thromboplastin time to assess these pathways. So how do we do? We use this for the extrinsic pathway. Which test is done? It's the prothrombin time. Okay? And for the intrinsic pathway, we do the partial thromboplastin time. And remember, both of these, they are common for common pathway also. The intrinsic pathway and common pathway by partial thromboplastin time, and prothrombin time by extrinsic pathway. Clear? How do we do prothrombin time? You must have done in your labs. What do we add? We add thromboplastin and we add calcium, and then we look for clotting. Which anticoagulant we use for this these tests? Yes? Yes, sodium citrate we use. Which concentration? No, that is the 1:9 is the ratio, but what is the concentration of the sodium citrate? It is 3.2% sodium citrate we use, and the ratio, as you said, it is 1.9. And we also have a test for this thrombin time also, okay, which assesses the common pathway. And once this fibrin is formed, what happens? This is broken down further to release the fibrin degradation products. Okay, the eventual clot lysis takes place. So this is measured by which test? That is measured by the D dimers which we have. So the clot dissolution takes place by the kallikrein pathway, which breaks down the fibrin polymer into the fibrin degradation products. We can measure this fibrin degradation products also by the isometric assays. Okay. Now coming to the prothrombin time. The prothrombin time, The normal range is 11 to 17 seconds. And you know, this measure varies with the with which type of the tissue factor, that is thromboplastin, we are using. So when you open a new vial, you always have to get the control. How do you do control in your labs? You take a pooled sera. Pooled sera means you collect the sample, blood sample from 5 persons, and you mix the serum of those patients, and then you do the, you estimate the prothrombin time. Similarly, you do for partial thromboplastin time, and that is the control for that vial. With every vial, you have to run a different control. This PT is increased in oral obstructive liver disease, vitamin K deficiency, and DIC. I'll be discussing in detail about DIC. Then we have this activated partial thromboplastin time, in which we mix plasma, phospholipid and platelet substitute, and then we look for the clot formation. The normal range of this PTT is slightly higher, that is 30 to 40 seconds. It is increased in DIC, liver disease, massive transfusion with stored blood, circulating anticoagulant and heparin. Then the third time is the thrombin time. Remember, all the tests which we do for the clotting factors, they are measured in time, seconds, okay? In this, we see the breakdown of the, we see the formation of the thrombin. It is ranges 15 to 19 seconds. It is increased in hypofibrinogenemia, raised concentration of FDP, dysfibrinogenemia, and hypoalbuminemia. These are the basic tests which we do in any routine lab for the assessment of the clotting factors. Can you tell me any other test which you do routinely which is not very specific? BT or CT? BT is done for the platelets, whereas the clotting time is done for the clotting factors. But it gives you just a rough idea, but it's a very useful bedside test to assess the coagulation profile of a patient, because that it doesn't require anything, whereas reagents which we use for this PT and APTT, they are slightly expensive. Now coming to the coagulation factor defects. They are classified into inherited and acquired coagulation defects. Inherited, they are further classified as X-linked recessive, which includes the various hemophilia. What is the other name for hemophilia? It is also known as the royal disease because it is common in the royal families of the England. Okay? So all the hemophilias, they are X-linked recessive. So all the males suffer, females are rare to affected. Then we have another inherited coagulation defect, which is very commonly seen, like von Willebrand factor defect. This defect is inherited both autosomal dominant and autosomal recessive also. But the most common, it is the autosomal dominant inheritance. Clear? Can you tell me something about von Willebrand factor? What does it do? Yes, very good. The function of von Willebrand factor are two functions. First, that it binds the platelets to the endothelium. You know, on the platelets, we have got the GP1B receptor, and this von Willebrand factor is expressed on the endothelium. So this binds the platelets through the GP1B receptor. Okay, so what does it causes? It causes the platelet adhesion. Okay, for the test of the von Willebrand disease, we use the adhesion test, which is done by the drug known as ristocitin. Okay, what does ristocitin do? The ristocitin drug, it enhances the expression of this GP1B on the platelets so that they adhere to the von Willebrand factor. But if there is a deficiency of von Willebrand factor, there would be no adhesion of the platelets, because the von Willebrand factor is deficient. Okay? And secondly, we have this acquired coagulation disorders, which include what? Yes? This include liver disease. They include the various anticoagulants which we use. And one which I'm discussing today is the DIC. That is disseminated intravascular coagulation. Okay? Now, I told you that the onset of the bleeding after the clotting factors is delayed after the trauma. It presents with the deep bleeding, either into the joints like hemarthrosis, into deep tissues like hematoma, or it can be large skin bleed like ecchymosis. Okay? Now, coming to the individual disorders, first one is the hemophilia. The hemophilia is a X-linked recessive disorder. Okay? This is the most common inherited disorder with serious bleeding. Okay? There are hemophilias, they are of various types, A, B. The hemophilia A is due to deficiency of which factor? It is deficiency of the factor 8, and B is due to deficiency of factor, yes, 9, and also it is known as the Christmas factor. So hemophilia B is also known as the Christmas disease. Okay? These two both are similar in all the ways. Okay? Only the tests are also similar. Only the specific factor assay, whether it's a deficiency of factor 8 or factor 9, will tell you which is the type of hemophilia. Okay? So it presents with easy bruising, massive bleeding after minor injury, particularly to the joints, hematomas, ecchymosis, and recurrent bleeding into joints leading to deformities. Remember, petechiae are absent. The clinical features depends upon how much is the factor present. If the factor is 6 to 40%, it will present you with mild bleeding, with mild trauma or surgery. Hemophilia A is seen 15% and hemophilia B 20%. Whereas when the factor level falls to less than 1%, then only the person will have the spontaneous bleeding. Otherwise, it would be normal. Okay? Otherwise, there would be only the trauma or surgery will precipitate bleeding. There won't be any spontaneous bleeding. So you can see hemophilia will, it can be managed easily if the patient is not exposed to any trauma or there is no surgery. Okay? Coming to how will you diagnose the hemophilia? What will happen to bleeding time in this? It would be normal because the platelets are normal. Okay? What will happen to prothrombin time? Yes, again it would be normal and APTT would be prolonged. And factor 8 is the most specific test for the diagnosis of hemophilia. Okay? वैसे it doesn't make any difference if you classify as hemophilia A or B because the treatment remains the same. You give a fresh frozen plasma. Because the factor 8 concentrate or factor 9 concentrate is so expensive that you limit the treatment to just hemophilia, and you must have heard their hemophilia society. So they all give the fresh frozen plasma. You can also do the factor 8 antigen assay. It is highly specific but complicated. You can do by immunoradiometric method or the ELISA techniques. Okay? So this is about the hemophilia. Same thing would be there about the hemophilia B also. Hemophilia B is indistinguishable from hemophilia A. And again the treatment is fresh frozen plasma. There is one more thing which is the hemophilia C, which is due to deficiency of factor 11. It is asymptomatic and there is less severe bleeding. And again, PTT and clotting time is increased. There is one thing called parahemophilia, which is due to deficiency of factor 5. Okay? Now coming to the von Willebrand disease. This von Willebrand disease is due to deficiency of the von Willebrand factor. One function you told me, it causes the adhesion of the platelets to the endothelium. The other thing which it causes is it stabilizes the factor 8. Okay? So there are two functions. It stabilizes factor 8 and also facilitates platelet adhesion. So how will this disease will present as? This is a unique disease. Then in this, along with there would be a deficiency of factor 8 also, and plus there would be a defect in the platelet function also. Okay? So there would be both of these deficiencies would be seen. This von Willebrand disease, that's why it is known as pseudo-hemophilia also, because in this you see a component of factor 8 deficiency. Okay? So what will it cause? It will present due to the factor 8 deficiency, there would be a bleeding in the weight-bearing joints, there would be hematoma, so, and also there would be an increase in prothrombin time. Second would be due to the platelet dysfunction. Okay? Because of this, there would be purpura, petechiae, bleeding from small vessels, and there would be a increase in the GI bleeding also. And because of the platelet defects, what you will get, there would be increase in the which time? The bleeding time. So there would be both deficiency of the factor 8 leading to increased prothrombin time and platelet defects. So you will get all the features of platelet defect also. Clear? This von Willebrand factor disease is classified into 3 types basically. In the type 1, there is partial deficiency of von Willebrand factor, and in type 3, there is a severe deficiency of the von Willebrand factor. So this is most severe, and this is the most symptomatic. The 2 is further classified into 2A, B, M, and N. In the 2A, there is a loss of heavy molecular weight multimers and decreased platelet dependent function. And in 2B, there is loss of heavy molecular weight multimers and caused by increased affinity for the glycoprotein. Then in 2B, there is decreased platelet dependent function. And 2N, there is a decreased affinity for factor 8. Okay? So what will happen in von Willebrand disease? Now you will tell me what will happen. The bleeding time increased. The partial thromboplastin time increased. This factor 8 assay, it would be decreased because it helps in the stabilizing the factor 8. Then you can do the von Willebrand factor immunoassay, which is measured by immunoelectrophoresis, radioimmunoassay, and ELISA. And also what I told you, the ristocetin cofactor activity. This is the most sensitive and most specific assay. It assesses the functional property of von Willebrand factor in the plasma by how it enhances the expression of the GP1B on the platelets. Okay? So, the von Willebrand factor, you see features of both hemophilia as well as platelet disorders. Clear? Actually, this bleeding disorders, they are very limited. You just have to remember few tests, not like anemia, we have got battery of tests, or not like leukemia, where you have CD markers. In the bleeding disorders, they are very limited tests, starting from bleeding time, clotting time, thrombin, PT, APTT, thrombin time, hardly any other test is there. And for platelet function, you have this ristocetin assay, and one more for the functional defects, which assesses the GP2B3A receptors. Now there is one more disease, that is disseminated intravascular coagulation. This is also known as DIC. This is actually the end result of the the whole coagulation system goes haywire. As the name indicates, there is a widespread intravascular coagulation. So what will happen, there is a, the etiology for this is usually there is an endothelial injury which leads to the formation of thrombi within the blood vessels. So as a result, all the platelets and the clotting factors, they are consumed. So the patient has both thrombosis and bleeding. And DIC is a medical emergency which is very difficult to treat. This is an acquired syndrome characterized by intravascular activation of coagulation with loss of localization arising from different causes. There is a whole spectrum of list which causes the DIC. It originates from and cause severe damage to microvasculature, and which, if sufficiently severe, can produce organ dysfunction. What will it lead to? Organ dysfunction means there would be a thrombi. So what will it lead to? It will lead to infarction. So what happens in this? There is a endothelial injury. Okay, and because of this, would be activation of the endothelial injury is the first step in the activation of the clotting pathway. So what happens? There would be a massive intravascular coagulation. There would be formation of the thrombi, and this coagulation is the initial event in the DIC. Okay, and when the multiple thrombi are formed, what will it lead to? It will lead to the first, there would be consumption of the all platelets plus the clotting factors. So what is the other name for the DIC? It is also known as the consumptive coagulopathy. Okay, because it consumes all the factors which are needed for the clotting, that is platelets and the clotting factors. So what will happen as a result? There would be a massive bleeding also when there is trauma, and this thrombi can cause the occlusion of the organs leading to infarction. So both of the process, that is the thrombosis and the bleeding, take place simultaneously. So it is a two-phase phenomena, hypercoagulable phase, and there is a hypocoagulable phase also. Then there is a systemic activation of the coagulation, which will lead to the intravascular deposition of fibrin, and which leads to the thrombosis of small and mid-sized vessels, and which leads to the organ failure in the form of infarction. Then there is a depletion of platelets and coagulation factors, which leads to bleeding. Clear? These two things should be very clear, that there is a coagulation and there is thrombosis and there is a bleeding. Okay? These all things you should remember, because DIC is one of the important topics from the exam point of view. Now, what is the etiology of the DIC? Initially, the obstetric complications were the most common, which leads to the development of the DIC. All the postpartum complications like the abruptio placenta, septic abortion, chorioamniotis, amniotic fluid embolism, and intrauterine death is the etiology of the DIC. In fact, in the earliest days, when cesarean section was not routinely performed, DIC was one of the most common cause of the postpartum death. Okay, because of all these complications, was earlier one of the most common cause of the maternal mortality. Then it can be seen following certain infections like viral infections like herpes, rubella, smallpox, acute hepatitis, and CMV. It can be seen following rickettsial infection, bacterial infection like meningococcemia, and gram-negative bacilli. Then fungal infection like histoplasma and aspergillosis also leads to the development of DIC. that is the pancreatic neoplasm. Then they can be lung neoplasm, then stomach neoplasm, and also the AML, M3 or the APML causes this DIC. Then vascular malformations like giant hemangiomas, aneurysm, coarctation of aorta, vasculitis, cyanotic congenital heart disease can cause the DIC. Then collagen vascular disorders, shock and hypothermia can cause DIC. It can be seen following massive tissue injury in the road traffic accidents, following head trauma, snake bite, anaphylaxis, heat stroke, graft versus host disease. All these things can cause the development of DIC. They cause the DIC because all of these release certain things which cause the endothelial injury. What happens in this? There is activation of blood coagulation, impaired fibrinolysis. The thrombin initiates the process of intravascular coagulation, and the plasmin secondarily activated results in the breakdown of fibrin and the coagulation factors. Okay? So in this, what happens? There is a massive tissue injury which leads to the release of the tissue factors. Also the tissue factors, they are released from the sepsis, which are usually because of any infection, and also the endothelial injury. All of these leads to the release of the tissue factors which initiate the process of the coagulation. Okay? And when this coagulation is activated, there is a thrombosis. And when there is a thrombus, there is activation of plasmin which cause fibrinolysis. And this fibrinolysis leads to the release of the fibrin split products. And you know, this fibrin split products, they are used for diagnosis of the DIC. You can diagnose the DIC by evaluation of this fibrin split products. Okay? And the thrombosis leads to the vascular occlusion leading to ischemic tissue damage. And this leads to the bleeding. So there is both thrombosis and bleeding. Can you tell me what would be the blood picture? When you see a peripheral smear, what you will see in DIC? Yes, one thing there would be thrombocytopenia. Then? Yes, very good. You get what you get is known as microangiopathic hemolytic anemia. So because of that, you will get the RBCs which are broken down. So the clinical features of the DIC are there because of the bleeding due to organ damage, due to microangiopathic hemolytic anemia and thrombosis. So what will be there? There would be a massive bleeding in the skin. You can see massive petechiae in the widespread in the skin. And also there can be gangrene also because of the obstruction of the blood flow because of thrombosis. What is this thing? Yes, very good. And what is this? Yes, see, these are the blood vessels of the skin which are showing the microthrombi. When you do the biopsy from them, you can see that there are small thrombi you can see in all the blood vessels. These thrombi, they are most commonly found in the brain, followed by heart, lungs, kidney, adrenals, spleen and liver. In the kidney, you can get microinfarcts or even bilateral renal cortical necrosis. In the lung, you get numerous fibrin thrombi can be seen, which leads to pulmonary edema and fibrin exudation leading to hyaline membranes. It can lead to Waterhouse-Friderichsen syndrome. There was bilateral adrenal hemorrhagic necrosis because of infection with the Neisseria meningitis. So the patient has got, this is there, in this, the causative organism is the Neisseria meningitis, okay, which activates the thrombus. Then they can be Sheehan's postpartum pituitary necrosis. They can be necrosis of the pituitary, and which is most commonly seen in the postpartum period. So, you will, how will you diagnose the DIC? For DIC, it is very important. You should be suspicious about the disease. Actually, DIC on the routine basis, it is diagnosed on a, it's considered to be a waste basket diagnosis when you can't diagnose anything. And obviously, it takes place secondary to any of the underlying disease. So there would be a history of the underlying clinical setting, and then there would be the evidence of thrombosis or hemorrhage or both. The lab investigations, there are no studies which are accurate, and actually serial tests are more helpful than a single test. In this, all the parameters which we see in the bleeding disorders, they all are deranged. That is, there is excess depletion of the coagulation factors. That is, there is a decrease in the platelet count. Prothrombin time would be, what will happen? Increase or decrease? Yes, it would be increase. The partial thromboplastin time will also increase. Thrombin time will also increase. And what will happen to fibrinogen? Yes? Yes, it would be decreased, but the fibrinogen degradation products would be increased. The fibrinogen degradation products would be increased. Okay? That is very important, that fibrinogen decreases, but the fibrinogen degradation products are increased, as there is a D-dimerase A. The D-dimers are also increased because they are formed by the breakdown of the fibrin. Okay? Then you can do the clot lysis test, in which you assess for the lysis of clot, which is increased. You have a euglobin lysis test, which is also abnormal, and you do one thing, that is paracoagulation. In this, you detect the fibrin monomers. So, the fibrin monomers are detected by this paracoagulation. And in the lab, when you do a blood film, you can see the presence of schistiocytes. Then you can do other tests, the prothrombin activation peptide, thrombin antithrombin complexes, and the antithrombin 3 level. These tests are very complex and they are not available everywhere. So the best test for the DIC is the fibrinogen degradation products.